values as they move forward in recovery. It compromises their ability to know what's okay for them and what's not okay for them, what's safe and what's not safe. And that really directly has results from this threat to their integrity, or this invasion of their integrity and their sense of self. So sometimes that definition is really helpful in terms of explaining for those folks. It's surprising for me when I talk to people, especially at Cottonwood, who come in for care, and they say, well, I don't have trauma. And I begin to hear their story, and it's just riddled with trauma. It is saturated with trauma. And often people learn to live with what I call the landscape of trauma. It's the landscape of their life. And so it becomes hard to differentiate that from what their normal experiences were. So having a clear definition is often very helpful for people. What we know about trauma is that it doesn't usually exist by itself when people have a history of trauma. A lot of our patients coming in and people in care that I've seen in private practice, about half of them who have PTSD also meet criteria for a substance use disorder, and that's according to research. So about 50% of people with a diagnosis of PTSD will also meet, with substance use disorder, will also meet criteria for PTSD. And that's why it's so important to assess for that. I'm often surprised when I talk to people who've been through multiple treatments for substance use and have never had an evaluation for their trauma, but that happens. And so my hope is that by educating, we can begin to really assess more appropriately for that and help people to heal those wounds as well. What we also know is that people who have co-occurring substance use and PTSD tend to have poorer outcomes in treatment and higher rates of relapse. There was a study in a hospital in Maine that looked at people who came in for substance use disorder and were discharged without ever having a diagnosis of PTSD attached to their chart. And when they brought folks back in, when they reviewed the chart after they had discharged, they found that about 60% of them also met criteria for PTSD, but it was never identified or diagnosed while that person was in treatment. So what we know is that when people have a substance use disorder and trauma, is that they often have history of multiple relapses, multiple treatment attempts. And so as we begin to work on both the substance use disorder and the PTSD, we can help people have more hope in their recovery. Often patients come in and they'll say, well, if I can just address my trauma, then I can go back and use again, or I can go back to drinking normally. And so I think it's important to educate people. My question for them is that old question, what came first, the chicken or the egg, right? So what came first, their substance abuse or their trauma? Or did their trauma come first and then their substance abuse? And the answer is, it doesn't matter which came first because they have a co-occurring disorder now. Both disorders are present and active. And so part of that work is learning to understand how does the substance abuse interfere with one's recovery from trauma, and how does PTSD activate substance use disorders. And so by giving people education and tools, that they can begin to recognize how those two disorders might interplay. We can understand too from research that PTSD is often a predictor of whether or not someone will develop a substance use disorder. It heightens someone's risk. So when I'm working with individuals who have PTSD, but they don't meet criteria for a substance use disorder, I assess anyway their use of substances, and I work to educate them about their risk factors, particularly when I'm working with a young adult or an adolescent, because what I know is that if they have PTSD, they're most likely going to be at extremely high risk from moving into problematic use of substances. So it's an important conversation for us to have with those patients and clients that we treat. So when we see someone that has either a major depressive episode or alcohol use disorder, that we know that both sort of pieces together double the risk for developing one or the other. So when people have trauma and they have either major depressive disorder or alcohol use disorder, chances are they're going to end up with one or the other. So if they have major depressive disorder with PTSD, they have a higher rate and a double rate of developing alcohol use disorder, if that statistic makes sense. And then co-occurring substance use and major depressive episodes predict poorer outcomes with higher rates of alcohol relapse for people. And people tend to struggle with feeling like, can I stay sober? Is there hope for me in recovery when I have co-occurring substance use and trauma, or co-occurring substance use and a major depressive disorder? And so really inspiring hope is helpful. I had someone say to me the other day, is there hope for me in all of this? And they said, someone told me once that you never recover from trauma. You never get back those years that were broken. And I said to them, there's always hope. And because you're here, because you're becoming more aware, there is hope in that. And we can recover and we can begin to connect with those parts of ourselves that might have been wounded in the past. So finding ways to encourage hope with people. And we'll talk more about how we do that. Am I keeping you guys awake so far? Yeah. All right. Yay. So what we know about trauma is that it is very much a sensory experience. And what I mean by that is that when we look at trauma and research, is that we know that trauma is often gets sometimes stuck in the neural pathways in the brain according to the sensory pieces that were present. So the way I describe it is this. If I were walking down the street and I got mugged and it was nighttime and I'm walking on a sidewalk and there's shrubs nearby and there's the sound of music blaring somewhere, all of those sensory pieces, the crooked sidewalk, the shrubs, the time of day, the music, and particularly the type of music will all become activating factors for me in the future with trauma. So understanding that sensory pieces are often a part of that narrative for people. And sometimes people don't have a formal narrative. They don't have a story that goes from point A to point B to point C. Often what they have is a jumble of really painful and overwhelming emotions. And those are coupled sometimes with a smell or a feeling on their skin or a light flashing or any number of sensory pieces. And often it's those sensory pieces that were formerly benign, but now they have a powerful network that connects them to fear, to panic, to violence, and feelings of vulnerability that are really difficult. One of the problems with trauma, I find, is that it doesn't fit our schema. It often doesn't fit how we think things should be. And we'll talk more about that when we're talking about traumatic grief, particularly. But often it doesn't fit in terms of our understanding. We don't have a file in our brain that helps us to understand what trauma is, or doesn't make any sense for us. And that's the piece that our brain then will go over and over and over again, trying to make sense of something that's senseless or that doesn't fit in terms of our understanding. We also know that trauma can often overwhelm the central nervous system long after the event has occurred. So when I'm talking with someone who has trauma, I can often notice when they may dissociate that we're getting close to something that's really painful for them. I find often when people are dissociating that they tend to look up and to the right. Sometimes they may tap their feet or they may shift a lot. They may have some repetitive movements in their body. I see a lot of foot swinging going on when people get a little dissociative. They may get a little far away look, because I know that maybe their central nervous system, as they're recalling the trauma, has gotten activated and overwhelmed. And so when we know that, what we can do is move away from things that we might typically say to people who have trauma. Sometimes in our innocence and not knowing, we may say something like, that was in the past. It's time to move on. And the fact is, when trauma it's trapped often in every cell of our body. So moving on for people isn't really an option. And so when we say that, often people walk away feeling ashamed or feeling hopeless about their potential for recovery. They often feel like something is wrong with them, or they feel like a bad person because they can't live on. Sometimes we may say, forgive and forget. So paying attention to that and continuing to educate ourselves about how people truly recover and how trauma impacts the brain, the body, our emotions. It is a whole body experience. One of the things that I also find to be true is that people tend to stay stuck in terms of trauma recovery unless they find meaning in their survival. And it's a hard thing to say to someone, because sometimes people get angry and they'll roll their eyes, or they'll say, what do you mean? What did it mean? It was a horrible thing. It was the worst thing that ever happened to me. How can you say that to me? How can you tell me that to decide what it means to me? It was terrible. And what I say to people is, we're not trying to assign meaning. You've already assigned the meaning to what you've been through. But sometimes that meaning these negative beliefs about ourselves or the world. It's those beliefs that tend to undermine our potential for recovery. The meaning behind people's trauma often might be, I am broken, I am worthless, I'm not lovable, I'm no good. And those are those early messages we may take away from our experiences of trauma. So beginning to explore our trauma and understand what it meant to us in a new way is really important in terms of our recovery. So we know that trauma truly is a whole body experience. It's not just something that was in the past that someone wants to rehash over and over again. It truly does change our brains and our bodies. We know that trauma causes documented alterations in our neurochemistry. So for instance, we know that often people who have PTSD tend to have lower levels of serotonin in their brains than people without trauma. And so we know that changes in serotonin for children can result in aggression and impulsivity. So when you think about maybe kids that you've worked with or known that have a lot of trauma, they tend to be somewhat aggressive and impulsive, right? They don't have very good control. Serotonin also impacts our mood, our sleep, our libido, our appetite, our perspective on the world. So knowing that maybe someone who has PTSD also has some changes in their mood that are associated with that. That's why sometimes antidepressants can be helpful when people have PTSD in reducing some of those symptoms and making it easier for them to do the work that's needed. Other changes that have been documented that are kind of interesting are, we know that when people when people move into talking about their trauma and their experiences, is that sometimes they get that faraway look. They may describe feeling numb or checked out. And so what research tells us is that often the brain is releasing an endogenous opioid that's equivalent to about an 8 milligram injection of morphine. So I don't know about you, I'm kind of a lightweight, but an 8 milligram injection of morphine would probably leave me feeling pretty numb and checked out as well. But that's our body and our brain kicking in to say there's pain there, and we're going to numb that out. So knowing that that there are changes in the brain that happen. Other changes are changes in the shape and the function of the amygdala, of the hippocampus, of the hypothalamus, of our brain's ability to regulate, to move forward, changes in our nervous system. People often move in and out between hyperarousal and hypoarousal. Either they're highly aware or they're not aware at all, which then makes it difficult for them to live in the here and now. So people who are hypo-aware, unfortunately, are at higher risk of being re-traumatized, right? Because they're not able to be as aware to those things in the environment that might indicate risk. So knowing that that might be a factor for them and teaching them what that means and teaching them how to reconnect. Mindfulness exercises and practices are often very helpful for interrupting some of that hypoarousal pattern. We talked already about ways that trauma changes the thoughts and perceptions of people. It's pretty profound when you've worked with people with trauma to hear the way that they may reflect on the world. Often it's a very dark and difficult place for them. They may feel hopeless. They may not be able to trust other people. They may not trust themselves. I was working with an individual recently who had a history of sexual trauma, and as a child was struggling with acting out behavior and so much shame for this person, and literally calling themselves a perpetrator. And it's that distortion in thoughts. And so ways that we begin to challenge that are education and compassion and teaching self-compassion for people with trauma. So we'll talk more about that as well as we go. And so we've talked about most of that. I'm going to move on to the next page. So I like to read quite a bit, and this is a quote from the book, The Kite Runner, and I felt like it really does reflect some of those sensory pieces that get trapped in the brain in terms of trauma. And I'm going to just read it and you guys can follow it around. And he's describing a scene where he witnessed an assault in an alleyway. And he says this, he says, "I became what I am today at the age of 12 on a frigid, overcast day in the winter of 1975. I remember the precise moment." Listen to the language. "Crouching behind a crumbling wall, peeking into the alley near the frozen creek. That was a long time ago, But it's wrong what they say about the past, I've learned, about how you can bury it, because the past claws its way out. Looking back now, I realize I've been peeking into that deserted alley for the last 26 years. What a powerful statement about how trauma gets locked in the brain. That story and that watching and realizing, and this is true for so many of our patients and clients that we treat, is that developmentally, when they are traumatized at a young age, there is a part of them that stays in that moment. I mean, there's a developmental part of them that freezes too, that gets stuck in terms of how they're moving forward with development. So sometimes when we're doing our work with trauma, we may encounter really young aspects of that person. Right? One of the questions I frequently ask someone when they're activated is, how old do you feel right now? Because I want to understand, at what age did that trauma happen and where developmentally did that person get a little bit stuck? And so I really like this quote because I feel like it outlines, and keeping in mind those sensory pieces and knowing how powerful. So for this person, a lot of things may be activating for them. There's a lot of sensory data in there. I know this is fairly basic, but I like to include it. And I am really happy to see the direction that we're going in terms of understanding trauma. I really, and maybe this is just me, but I was really happy when we moved away from labeling PTSD as an anxiety disorder. It felt sometimes like a way of minimizing it. I appreciate now that we consider it a trauma and stressor-related disorder, that we have new understandings emerging all the time. And I think that is really the way forward in helping people in their recovery and helping them to heal and to be empowered. So I feel like the ACEs study, although it was a long time ago, back in 1995, really did lay the foundation and began to help point us in a direction of a fuller understanding of trauma and its impacts. So for those who maybe aren't familiar with the ACEs study, and bear with me for those who are, I don't mean to be telling you something you already know, but it's worth reviewing again. But the ACE score was developed looking at what is called adverse childhood experiences. And this study was an epidemiological study of about 17,000 subjects, and it was done in 1995. And it's been sort of kind of redone in different ways, and the data continues to emerge in much the same way. But looking at this link, and what we're looking at is the link between childhood experiences of trauma and adult health. And so they followed 17,000 people who had experiences in their childhood, and then they compared them to people as they compared them to their adult health records to see if there was a correlation. And so an adverse childhood experience is defined as a chronic, unpredictable, and stress-inducing event that some children face. So that's a broad definition, but in that definition can be things sometimes like poverty, right? So people who aren't getting proper nutrition. It may be a parent who's ill. It may be some form of abuse, chaos, instability, unpredictability, all of those pieces that can sometimes affect children. So here's what they found, and I think, and there's more data around this too. I just picked a few that stood out for me, but for each event, a person is assigned a score of 1. And so here's what they found, is that individuals with an ACE score of 4 or greater were twice as likely to be diagnosed with cancer in their adult life as those who had not experienced any childhood adversity. So beginning to explore, how does a diagnosis of cancer relate back to, and does it inform, does trauma, is that a predictor of adult health? And looking also at how trauma erodes the end caps on our DNA, how it makes us more susceptible to aging and illness. Also, individuals with an ACE score of 4 were 460% more likely to suffer from depression as someone with an ACE score of 0. Now, I've never met someone with an ACE score of 0. I'm sure that they exist. Most of the folks coming in for care at Cottonwood and that I've worked with historically always have an ACE score. But if you're up at 4, you have a 460% increased risk of depression, according to this study. It's another interesting one. Think about your female patients who have autoimmune disorders. Right? So for each ACE score that a woman had, her risk of hospitalization related to an autoimmune disorder rose by 20%. That's per ACE score. And then an ACE score of 6 or more shortened a person's estimated lifespan by almost 20 years. So when we look at the data and we look at sort of what the study points us toward, it helps to broaden our understanding of how trauma impacts the body. So when we look at this information, what we can't say to a person with trauma is get over it. That was in the past. Don't let it bother you, right? Because what we know is that it's in the body, is that it affects every single cell of our body. And so with that understanding and we move forward in our PowerPoint, I just want to say keep that as foundational information. So a couple different types of trauma I think about, and as I'm assessing people, I want to understand, because often they have different presentations. So we have individuals that we might see who have a single episode of trauma, and they never really had anything else that might constitute trauma before. Right? So typically when we have those people coming in for care, and depending also when the trauma might have occurred, so developmental factors are a consideration. If their house burned down when they were 5, but everything else was pretty normal, it may have impacted their development, their characterological development, and things like that. But we have adults who have single episode trauma, a car accident, you know, a loss of job or illness. You might tend to see these clinical presentations. So depression, substance use disorders, anxiety adjustment disorders, those might be common clinical presentations. When we have people who have trauma that is complex and developmental, and this is by far the vast majority of people that I've seen and worked with, are people who have a history of pretty significant childhood trauma. And it's the kind of trauma that goes on and on. It's the kind of trauma that happens on a daily basis or a weekly basis, or it is, I said earlier, it's the landscape of their life. Right? Maybe they grew up in an addictive home where they were physically abused. There were poor sexual boundaries in the home. They might have been sexually violated. One of their parents died, and the list goes on. And there's like a whole lot of trauma that is impacting them. You tend to see a different kind of clinical presentation. So in there, you might tend to see personality disorders. So I'll reflect on this a little later. But there's a 88% correlation between childhood sexual trauma and the development of borderline personality disorder. 88% correlation. So knowing that trauma does impact personality development, and so then we tend to see people with struggles with characterological development. We tend to see more mood disorders, eating disorders, self-harm behaviors, and substance use disorders, difficulty with self-regulation. So people who can't stay within what we call the window of tolerance. They're either in hypoarousal or they're in hyperarousal. They can't really be able, they're not in a place where they can tolerate feelings well. They tend to be somewhat explosive or numbed out and shut down, and they vacillate maybe between the two states, but they have trouble with self-regulation. They may have developed compulsive patterns of behavior that might include process addictions. They may have sexual compulsivity depending on what kind of trauma they might have survived. They may have compulsive spending habits or gambling habits. Those are all pieces that I've seen. And then issues for folks with chronic pain as well. And I'll talk more about that as we go too. So when we think about development for children and we think about what they need, I mean, one of the things that I always consider when I'm talking to someone is the age at which a trauma occurred. So for those who maybe had that landscape of trauma in their childhood, what we can understand is that it's going to impact so many different arenas in terms of their development. So kids are egocentric. And so I have a son, he just turned 13, and he's still pretty egocentric. His favorite store right now, I'd have to say, is Target, because you can get a lot of different things at Target. He also likes to shop on Amazon in this time of a pandemic. But let's imagine that I went to this store and I came home with a giant bag, Target bag, and it had maybe a box shaped like something he might want. Because he's egocentric, he's probably going to say, hey, Mom, what did you get me from Target? Why? Because I'm his mom, I'm in his house, and I happen to have a bag from his favorite store. So when children are egocentric, keep in mind that their perspective is that everything is about them, because of them, and for them, right? And so it's really cute that my son might assume that that bag is for him. But when you maybe consider a different child in a different home with a different parent, right? a parent who's maybe abusive to them physically, a parent who is unpredictable, a parent who is violent, a parent who is drinking, a parent who is depressed and locked in their room, a parent who doesn't show up for them, abandons them. That same concept applies. That child will consider that whatever's going on is about them, because of them, or for them. Right? I caused it. Okay, I've often heard people as adults say, I am terrified of connecting with people because I am really afraid once people know me underneath, they're going to leave. And that's that core belief that comes from egocentricity in childhood. That belief that got attached early on, there's something really bad about me. Okay? Children often aren't able to reflect that maybe their parent is ill. We tend to put our parents on a pedestal as kids. We tend to think of them as all-knowing until we're maybe like 13 or 14, right? And then we begin to roll our eyes at them. But as small children, they have a hard time understanding that maybe what's going on for them is about their parent. For us as adults, we can maybe reflect back and say, well, my parent wasn't well, whatever they did, that was really about them. But children often don't have that capacity. So they'll internalize that, and they'll take that sense about themselves that there's something really wrong with who they are. They're unlovable. No one would ever love them or connect with them. People will always leave them. And those tend to be those negative beliefs that connect with trauma, and particularly for children in development. Trauma also for children impacts developmental milestones. So you see a lot of developmental immaturity for people with trauma. So you might see kids who, instead of doing what they should be doing, which typically you think about children and gradually individuating, developing their own sense of identity. But what if in their home life, it wasn't safe to individuate? What if they had to stay and take care of siblings so they wouldn't get beaten up, or so that their kids could get fed, or they had to take care of their mother, or whatever might have happened? Is that children will often leap ahead developmentally. They'll seem very mature sometimes, right? Or they'll seem like they're handling things okay. And in fact, what they've done is that they've just leapt over some of those developmental milestones. And when you see them in long-term relationships, they may tend to struggle because they never really learned how to individuate, and they don't really have a true sense of themselves. Let's see. I'm actually going to leap ahead a little in the sense of time. I want to spend a little bit of time today talking about sort of our current environment as well, because there's a lot of trauma themes in there. And I know we're all going to be seeing an influx of patients coming in who are quite activated by our current events. And I want to just spend a little time talking about that. So one of the factors that I think about and that I've seen quite a bit of, and I think we're going to see more of, is understanding traumatic grief. So when we consider trauma and grief together, you might think about people who have a trauma where there's a death or a loss involved. I remember working once long ago with a person who'd lost both of their children in a terrible accident, and both of their children, they had two children, and both children died at the same time in the same way. Now, is that a trauma? Is that a grief? And the answer is yes. So understanding that traumatic grief is very much like a tsunami. It's that thing that comes and wipes out someone's whole understanding of how the world should be. It interferes with their sense of meaning, their sense of purpose. It's a very confusing event, and we're seeing quite a bit of that today. But sort of knowing and being able to differentiate. Sometimes when someone has traumatic grief, we just assume that that's just grief and that will get better without really understanding the implications of trauma. And I actually find that using kind of interventions that I might apply with someone with PTSD is much more effective when I'm exploring traumatic grief. I also find that people who have a history of trauma, because of their emotional dysregulation and their struggles, is that they may struggle with being pretty depressed, and sometimes, quite frankly, there's a higher risk of suicide. And I want to just reiterate that, particularly if you're working with someone who has traumatic grief, is that you need to assess for suicide and then assess again and assess again. And I want to underline that and put an exclamation point by it, because I think that as we kind of move forward from this current era, that we're going to probably, unfortunately, see a rise in suicides. We have individuals in our world right now who have a history of childhood trauma and who are now quite activated by our current environment. Maybe that trauma was quiet, it settled down for them, perhaps they'd done some work around it. And then in our current environment of unrest and fear and all of the things and the conflict and all of the things that we're all walking through on a daily basis, the trauma just pops right to the surface again. I'll give you an example. I was working with an individual recently who grew up here in the States, but was a child of a migrant family, and they went from place to place and working, on farms and things like that. And that person's whole life was spent being bullied. They would go from school to school, being picked on, beaten up, called terrible names, and really struggling with racism and just terrible, terrible things on a regular basis. So as an adult, that person's pretty successful, educated. They've made a lot of strides. They're fiercely resilient. But guess what? Guess what happened this year, right? Think about all of the explosion of and just our increasing awareness of racism and police brutality and riots. And for that person, that old wound has now popped back up to the surface. And so knowing that for a lot of our folks, this environment is often very activating. When you think about the level of conflict and unrest and arguments, think about people who grew up in homes where they were in a dysfunctional family and nothing felt safe. Right? And they felt like they were living in a constant era of threat and no one was agreeing and opinions weren't allowed and no one could sort of get together. How is that any different than where we are today? And we're not going to talk politics today. It's just an observation of our culture and knowing that for a lot of people, their trauma has become incredibly activated. Now, let's add into that mix that as human beings, we have to stand 6 feet away from each other. We're wearing masks and we're all afraid of each other. Right? It's allergy season here in Tucson, and I'm afraid to sneeze. You know what? Because we're afraid of each other, right? It doesn't feel safe to connect. It doesn't feel safe to hug. It doesn't feel safe to stand close to one another, to go visit one another. And we're sort of quarantining and staying out of public as much as possible. So when you mix all of those pieces together for people who have histories of trauma, we need to just be aware that that risk of ongoing depression and risk for suicide are very high. For those people who've lost someone in this current pandemic, that is called traumatic grief. Okay? It is often for people who have trauma and grief, it's that loss that broke the rules. It's not the way that was supposed to go. So I see this often with parents who have lost a child. Right? I cannot begin to imagine that type of loss. That is a traumatic grief. Even if they knew the child was going to die eventually or the child had been sick for a long time, it is a traumatic grief for that person, all right? It is both a trauma and a grief. And so understanding how those things tie together, and I compared, as I said, to a tsunami. So, kind of just tying into what we were talking about earlier in our current environment of trauma, and as clinicians, as you are working in the field, you're going to come across people, as I said, who are really activated and their earlier traumas have just popped right back up. Let's just look at this list so far in 2020. Here we go, right? Estimated loss, this was a few weeks ago, 300 million jobs globally, right? Increases in depression and anxiety from 3.9% in 2018 to 13.6% in 2020, and that might even be higher now. We're not at the end of this deal. Skyrocketing cases everywhere. I think we're all in the red zone now. A couple weeks ago here in Arizona, we were at the epicenter of the global pandemic. That was it. Congratulations. And our mountains were on fire and it's really hot outside. So we're sort of living in this very interesting time. Again, it's activating for people who have histories of trauma, and we just need to keep this in mind as we're providing care and supporting our clients, that we keep in mind. Food shortages for people being afraid of being evicted because they lost their job and they don't have financial resources, supply shortages, police brutality, racism and rioting, school shutdowns, and arguments. Should schools go back in? Should they not? Right? Parents, I know for myself, it's that question of, is it safe to send my kid to school? Is it not safe to send my kid to school? Okay? Feeling that threat, that potential loss, the risks that we're all sort of facing right now. These are all our current times. And again, keep in mind that for people who have earlier histories of trauma, these things are devastating for them. They are incredibly activated. And I can tell you that because we as a facility at Cottonwood have seen an increase in our numbers of admissions. Right? People are struggling out there. They're hurting, they're afraid, they're wounded, their old wounds have come and opened back up again, and they need our support. Lack of medical equipment, loss of faith in global leadership, for some loss of hope. And then we talked about quarantine with excessive loneliness, periods of anxiety for people. So that's 2020. Now we're all hoping 2021 is a better year, right? We're all just going to sort of put that out there. But I just want to honor this space. And if this is what's going on for us now, imagine for people who carry a weight of profound childhood abuse, who have a neurochemistry that is already activated by trauma, who have profound sense of dysregulation. They have trouble staying in the window of tolerance. Is it any wonder that drug overdoses are on the rise, that people are relapsing who had long periods of sobriety? These are, as I said, unprecedented times. And so as trauma clinicians, it is really, really on us to do our best to have a deepened understanding of trauma and its implication. And for those of us in this time who are working with trauma survivors, to know it and to just say it out loud, to talk it through with people. It's funny, I was talking with some colleagues the other day, and we were saying, you know, we used to be like pretty surface. Someone would say, how you doing? Oh, I'm all right, how are you doing? You know, and now we sort of check in and assess, well, am I really doing okay? You know, do I have I'm a little stuffy. Do I have coronavirus? Am I okay? Am I gonna, you know, so we do a deeper check-in, and maybe we're a bit more honest, and maybe that's a gift in 2020, is that ability to just be more honest. But as clinicians, I think we need to just be more upfront in assessing and talking this through with our clients and just honoring for them. Again, some images. These are just in the last several years. Just take a look for a minute at all these images. This is what we see every day. You just turn on the news, click on your phone, right? I've just kind of stopped looking. I limit myself to maybe 1 peek a day, just so I know what's going on. This is overwhelming, okay? All of these pieces are overwhelming. And we also talk about mass shootings, right? In the middle of that, we're still shooting people here, right? That's another piece, another layer, and we just layer it on and layer it on in our world. And you think about the impact. I mean, I know for me looking at these images that it feels overwhelming. I can feel myself sort of just step back, and it's hard to take it all in. Huge forest fires, the rainforest burning, Australia burning, you know, just all these sort of struggles that we're having. So I just wanted to capture that a little bit in terms of just the ongoing struggles that we're facing as a world. So I want to just kind of touch on this really quickly, because this ties into what we're talking about with traumatic grief. And just as you're assessing for this, because you will see this, whether it's the loss of a sense of hope or the loss of a loved one in our current times, or whatever might be happening, is that what we diagnostically call that is complicated grief, versus an uncomplicated grief. I don't know that grief is ever uncomplicated, right? But it's a complicated grief is often occurring in the aftermath of traumatic loss and can involve symptoms of PTSD. So sometimes we might be assessing for grief, and what we're going to run into instead is PTSD. And it can be woven into this story of complex loss and bereavement, and can include multiple losses. So when we think about maybe some of our elderly folks who live in nursing homes, maybe who got hit by COVID and multiple losses for them, right? Or people who have multiple losses in their life. Sometimes I think as people age, they tend to start losing a lot of friends and colleagues that they've known for a long time as they approach the end of maybe their own life. I know this happened to my dad, that many of his friends have gone, and those become, you know, those multiple losses can often complicate the grieving process for people and can often be traumatic. So other factors for people with complicated grief, which again has elements of PTSD, might have trouble carrying out normal routines. They might tend to isolate from other people, withdraw from social activities, experiencing depression, deep sadness, guilt, or self-blame. And then they tend to blame themselves. We typically might call that survivor's guilt, right? And so there's a lot of that, or feeling for people that life isn't worth living without their loved one. I've had parents say to me, I feel like, you know, when my child died, I feel like now it's my job to go and be with them. Okay, it's that distorted thinking that often comes in the wake of PTSD. They feel like they failed as a parent, they should have prevented their child's death. And so I think we're going to see more and more of this as we emerge from this current era of COVID-19. When we're thinking about traumatic grief, I really like this quote by C.S. Lewis, and this is an old book called A Grief Observed, but what a powerful quote. And I want us to think about this in terms of how we might conceptualize traumatic grief. And it says, for in grief, nothing stays put. One keeps on emerging from a phase, but it always recurs. Round and round, everything repeats. Am I going in circles, or dare I hope I am on a spiral? But if a spiral, am I going up it or down it? How often will it be? For always? How often will the vast emptiness astonish me like a complete novelty and make me say, I never realized my loss till this moment. The same leg is cut off time after time. What a powerful quote, right? And I think we see this with our folks with trauma too, is that they stay stuck in that spiral and they go round and round and round, and they can start to feel really hopeless. I was working with an individual recently who had very, very complex trauma, and they'd done a ton of work, really honoring the work that they've done. But sometimes what I find for people when they're in this cycle, whether it's grief or trauma, is that they can get stuck in those details and be so activated that they actually get worse rather than better. And so I think that's true for traumatic grief, and I think it's true for treating PTSD. But I really like this quote as we sort of think about this era of traumatic grief that we're moving into. So when we're talking about just, again, our current environment and thinking about PTSD for folks and losses, there's so many losses for people. I'm wondering how many of you out there attended graduations for your kids on Zoom, right? Or parents in nursing homes that can't see their family. I read an article in the New York Times about a woman who was talking about that her mother has dementia and she may never remember her again, and that being there for daily visits in person really helped, but through a window where they can't really talk and their mother becomes increasingly confused. There's a loss implied in that, and there's also a trauma of not being able to get to the person you love, not being able to do the thing that you needed to do. A loss of a sense of community, loss of finances for people. And when we think about trauma, it's important, particularly even when we're thinking about childhood trauma, sometimes it's helpful to think about what was lost in there for people and to teach them how to grieve those losses as well. Sometimes people get where PTSD can get a little complicated in with the losses. Talking to someone recently who lost a father, and they'd been working over the years to try and have a better relationship with their dad. Their dad had always been absent. They hadn't really connected, and then their dad passed away. And the loss isn't just their dad died. The loss is the loss of their childhood father, the loss of ever being able to connect to them in a way that was meaningful. So when we're looking at PTSD and we're looking at trauma and we're looking at grief, it's important to understand how those all flow. It's an interesting thing, and I don't know if any of you have seen this, but sometimes I've heard this story actually repeatedly, is for people who maybe had childhood sexual abuse, is that often their abuser will suicide. And so imagine that complication for that individual is that they never really felt like they were able to process that, and that person's gone, and they feel stuck in that process of recovery from trauma. Right? It's a storyline that I've actually heard repeatedly, and I think about how that might complicate recovery for someone. It becomes part of that really difficult picture that they're already carrying, and it makes it really tricky for them. These are just a few ideas of things that I might think about when I'm talking about working with a particularly traumatic grief, and we're working with folks right now in our worlds that maybe are struggling in this arena. These are some just clinical interventions that are helpful. And sometimes I use this first one in treating PTSD that isn't involving grief as well. but it's called a loss characterization, which is an intervention that we might typically use for grief. I can tell you it works beautifully for trauma. So in a loss characterization, what I might have someone do is I might have them write for me their story from a third person perspective. They're telling me the story of that person, and they're writing it as though they're writing about a friend that they love and care about. So they can only use compassionate language. And what I want them to talk about is what happened before the trauma and what was life like after the trauma, or what happened before the loss, what happened after the loss. And I want them to really characterize the shift that they experienced, what was different for them because of what they went through, right? What did they lose in that process, whether it was their innocence or their trust or their connection, or whether they lost a person or they lost their perspective, whatever that loss was. I want to see if we can capture that in writing. I challenge people a lot in the direction of self-compassion. Now, I guarantee you, if you tell your client, we're going to work on self-compassion, they will roll their eyes at you and maybe give you the finger. I don't know. I get a lot of eye rolls when I talk about that. But when I'm talking about self-compassion for people, what I know to be true is that you cannot be in self-compassion and self-destruction at the same time. Right? The two cannot coexist. So I'm always going to lean in the direction of self-compassion, and sometimes just giving education for people, normalizing their behavior, normalizing their experiences, giving voice to that with a compassionate perspective teaches them also to have self-compassion. Sometimes people struggle with self-compassion because they assume it means self-pity, and the two are very different. Right? Self-pity is that thing that we all want to stay away from, right? I don't want to feel sorry for myself. So self-compassion isn't self-pity. They're very, very different. Self-compassion is just that lens of understanding with the responsibility to move forward in a different way, right? So I teach people, I really work to teach them, how do we find your strength? And I'm going to go stand by your strengths and point them out to you over and over again until you can go and stand by them yourself, right? I want you to know that you're compassionate, know that you're kind, know that you're intelligent. And so the more that we can kind of interweave those ideas into our work with patients, the more that we'll see them begin to move in that direction of self-compassion. So the loss characterization is a helpful tool in doing that. I use a ton of art therapy. I'll tell you, it is a game changer if you haven't used any art therapy. I am not an art therapist, right? I draw stick figures. But a lot of our clients and our patients, if you give them permission to be creative, are incredible. I find that with art, for people to be able to tell their story through imagery is sometimes easier than telling their story with words. I read a statistic once that the average trauma survivor needs to tell their story about 50 times before they begin the process of recovery. And since then, I've heard it's telling it over and over. It's taking that box of shame or pain or woundedness that we might have buried and taking it out of the ground and integrating it into how we understand ourselves, into really celebrating our resilience, which we'll talk more about in a little bit, into celebrating how we survived and understanding that. So art therapy is a really powerful modality. Sometimes I'll use collage for people. I've had people do some incredible collages. Sometimes they're hard to look at. Sometimes I just want to get those distortions they have in their head out into imagery, and then we can talk about them, and then we can begin to dismantle them. But sometimes people are too ashamed to tell you with words what happened to them, or it's hard to verbalize, and so art therapy can be really powerful. I do a lot of work for people who have traumatic grief with linking. So for instance, I think sometimes we push people too hard to move on, to say goodbye, let go of their loved one. And really, we want to teach them how to hold on, how to remember, how to pull that person forward in a way that really honors their existence. I think sometimes people get stuck in the process with traumatic grief because they feel like to grieve or to move forward means I have to let that person go. I have to let my child go, right? And they don't want to let their child go. And so I'm always working to teach them to hold on, to find a link. What did you learn from that person? What was beautiful about them? Ask questions about their loss, right? Even though it's hard, sometimes we don't want to and we tiptoe around that. I just go right in because I find that that person really, really wants to talk about that person they lost, and it's us. We have the issue sometimes. I know for traumatic grief, I know that when we're talking about somebody who lost a child to suicide, it is horrifying. As a parent, my own countertransference may get in the way. I may say, ooh, if I talk about that and I recognize how vulnerable that person was to that, how they couldn't predict it, couldn't plan it, it means I'm also vulnerable too. And that scares us as humans to think that maybe that could happen to me. And so I don't want to talk about that with them. I don't want to know, right? I don't want to hear the details because right now it's easy for me to keep you over there and that happens to that person over there. It happens to all of us. And so as we can begin to ask questions and to get comfortable just being in someone's sadness without trying to shut it down and giving them permission to grieve, asking them specific questions when they've had a traumatic loss. Tell me more about that person. Tell me what that was like for you to find that out. Tell me about what you know. Tell me what you want to know that you don't know yet. Those are all pieces that can help someone to begin to shift. Again, we're integrating that trauma into their understanding of themselves. If you're struggling with countertransference, you're dealing with someone, whether it's with trauma or with traumatic grief, is really get consultation, increase your awareness of any possible countertransference or vicarious trauma response that you might be having. Just being really aware as a clinician helps you to be an even better clinician. And being honest when you're struggling. Try to stay away from, pat answers, and we'll talk more about that. So there's some ideas with PTSD and with grief about that sometimes that thinking process can become addictive, right? It's that when someone's, particularly with what I find with people who have PTSD, is that sometimes they get into a lot of suicidal ideation. And it can be scary, but sometimes what I'll have them do is like an art project to close the door on suicide, right? I want like a door and I want it barred shut. I want like a keep out sign on it because I want to get a visual, because sometimes people will get into that addictive process with trauma or grief and they'll keep thinking about it over and over again, or they'll keep thinking about suicide as an out for that experience. And when they feel bad, they go to that idea and they go to that idea and the idea strengthens and strengthens. And so I want to just give a little visual bypass for someone. So if they're thinking about suicide as a result in that addictive thinking pattern, then I want to challenge that a little bit. And I want to have some kind of visual image that it's like a stop sign for them. All right, let's see. So when we're talking about helping people process trauma and traumatic grief, I would say a couple of things to avoid would be moving too quickly. And sometimes I think we're all guilty of this. Maybe we've spent several sessions with someone and they keep wanting to go back to the event that we've already talked about. And maybe we feel frustrated. And I'll tell you, doing this work with patients is sometimes exhausting. Sometimes it takes a lot of our own energy because it is incredibly painful. Right? Maybe our own wounds come up. Maybe we're exhausted or we're feeling impatient or we have something else going on in our own life. But being patient is really important, and avoid moving too quickly. Staying in that story with them and trying to understand why is it important for them to talk more about this today. What is the piece that we're missing that we haven't really gotten to yet? Avoid shutting down the process. I'm an EMDR provider, and sometimes when I'm doing an EMDR piece with someone, sometimes they might get into looping, and I want to hurry up and move them along, right? Because maybe our hour's winding down and I want to get on and say that we completed our session, and that's just my own countertransference, right? That's just me wanting to hurry up and just clear this out of the way. Patients have their own process, clients have their own process, and it's not our process. So knowing kind of when we're in that zone and really stepping back from those moments is really important. Sometimes we want to assign meaning to people that doesn't fit for them. And so just be aware of that sometimes our own sort of values or beliefs, things that are important to us, we might want to insert those. And so just being careful about that, careful using platitudes. These are all things that I think we all know. And then also be careful getting stuck. So I was talking with someone the other day, and they, as I said, it was the individual who wanted to call themselves a perpetrator. And they sat with their arms crossed like this, and they were just looking at me, and they said, I am a perpetrator, and you can't change my mind. And I said, well, I think we're going to disagree. And they said, well, we're at a stalemate. That's what they said. So we just sat and kind of stared at each other for a few minutes. And I realized how easy it is sometimes to get stuck with people in their own distortions or their own struggles. And sometimes they're kind of projecting onto us their own hopelessness or fears about recovery. And if we can step back from that, if we can move into a new way of thinking, sometimes education can be helpful when we're stuck in those moments with them, inserting a little bit of education, exploring their process. Why is it important that you feel so stuck right now? Why is this label important for you? Moving it out of that stuckness as much as we can, and just being aware when we are getting stuck. So I'm going to talk a little bit about resilience here toward the end, and we have just about 25 minutes left. So when we're looking at resilience and resilience studies, I mean, resilience is this idea that we will return back to a state after being abnormal, after being sort of bent or twisted, or and so I like that definition of resilience, but I also feel like I don't know if we have trauma, return back to a normal state. I think sometimes we go to a new state of being and a new way of understanding. And so I want to talk about how we can view resilience and our clients through that lens. So these are sort of, when we're looking at resilience studies, the three basic concepts that we can think through. One is individuals who've experienced traumatic events, but they're able to recover well. So that's one sort of phenomena of resilience that researchers are looking at. Also individuals who belong to a high-risk group, but have a more favorable outcome than predicted. So say, for instance, you grew up in a home where there's addiction and you yourself don't grow up to be addicted. That would be someone who would fit into that group. And then lastly are individuals who demonstrate a positive adaptation despite life stressors. So as a result of trauma or in spite of trauma, that person is able to adapt and keep moving forward. So those are the three aspects of resilience that research is currently focused on. When I'm working with someone, I start right from the get-go of thinking about how is this person resilient. Sometimes that's hard. Sometimes I have to look hard and be thoughtful about that person. But I always like to start here because it helps me in terms of how I'm viewing that individual, and it helps me to look for ways to help them shift out of their own stuckness. So I would always find that resilience is masquerading as a problem behavior. Now, that being said, I'll just give you an example. I would much rather, this is a secret, so don't tell anyone, right? But I would much rather work with an angry, snarky adolescent who's got their middle finger up in the air and they're glaring at me. I would much rather work with that person than someone who's completely shut down with depression and powerless and voiceless and hopeless. And I'll tell you why. Because that problem behavior, the middle finger, the anger that I'm seeing, to me, that's resilience. That's that person's voice. Now it's an angry voice, right? It is maybe hell-bent on letting me know they don't want to do this work. But to me, that spark is still there, and that is a resilient piece of that person. That person has not laid down and given up. They're fighting. Now, they might be fighting me at the moment, and that's going to change, but I can respect that that piece is really, really important, and I'm going to honor that. I also think that resilience lives in the trauma wound, and unless we really know what happened in those moments and we understand that wound, it's really hard to embrace resilience. So I like to know, like, not just what happened to somebody, but how did they get up the next day? How did they get through that moment? Because that's where I'm looking for resilience. I like to ask people, what are you most proud of in spite of what you've been through? Because that's a resilient piece that I want to know about. And so understanding the wound is important, understanding how they managed that wound. Even if it looks dysfunctional from the outside, there is a resilient human being under there trying to survive. So I want to look for that. And then really knowing that in order for someone to recover, we have to understand and figure out where they're resilient, and then I'm going to build on that. Now I'm going to see if this is going to work for me. Nope. Hold on. Bear with me here. Nope. Oh man, this is going to make me sad. All right, well, I'm going to have to just tell you about that.
Hello. Hi, hello.
Yes?
Oh, hi. I was on the webinar and I got kicked off, so I called back, but then it blocked me out of the call. So I just wanted to make sure I was still able to hear.
Yes, you are.
Oh,
Definitely.
okay, yeah, I was on the webinar the whole time, and I don't know, it just knocked me off, and then every time I keep trying to redo it, it says I can't, so I saw that there was a number I could call, so I was hoping to listen to the rest of it.
Perfect. We're
So
still
sorry about
going.
that.
No problem. All right, well, I had a nice little video that I tried ahead of time, and now it doesn't want to play. So I'm going to tell you about it instead, if you guys are all right with that. Okay, so if you ever saw the movie Castaway with Tom Hanks, there's a really terrible scene, right? It's the scene where, if you've seen the movie, where he's on the island and he has a toothache and he's in a cave at night, so he's by himself and his tooth is hurting and he's got all these packages that had washed up on the shore from the plane crash. And in one of the packages was a pair of ice skates. And so I like to think about this with our patients and clients. It's a little bit funny, but I like to talk to them about their ice skate behaviors. So what we know in the movie is that in the moment of that pain, Tom Hanks reached for that ice skate in the cave at night and he put the blade against his tooth and we all sort of go, oh, and he takes this rock and he smashes the tooth and it goes flying, right? And we all kind of go, ugh. And there's a part of us that really honors the fact that he could do that and he had to do that to save his life, right? Now, if we fast forward in the movie, we know that Tom Hanks gets rescued. Sorry, it's a spoiler if no one's ever seen the movie. But we know he gets rescued and he goes home to his apartment. Now, if Tom Hanks had a toothache then and he was still knocking his teeth out with ice skates, we would call that dysfunctional, right? So for our clients, understanding that they have ice skate behaviors, there are behaviors they learned as a way of surviving their environment and their dysfunctional family. And now in their adult life, it's getting in their way, right? They're back in their apartment like Tom Hanks, they're still knocking their teeth out with ice skates. So I want to know what their ice skate behaviors are, and I want to honor them, and then I want to learn some other way of coping. So honoring those ice skate behaviors, whether it was, I worked with a couple of individuals who, as a way of trying to navigate through sexual trauma, had to sort of allow things to happen to them that just create incredible shame. But in that moment, that's how they survived a really horrific event, right? That would be an ice skate behavior. But carrying shame about it later or reliving it in ways that are self-defeating, then that becomes problematic. Right? So we have to sort of help them understand and talk about what their ice skate behaviors are, and knowing moving forward, how do we put the ice skate down and honor that's what we did to survive. We can honor that without shame, and we can move forward in recovery. So I'm sorry the video wouldn't play. I really did try. What I know about trauma, and what you guys probably know as well as you're working with these folks, is that trauma changes the story for people. Now, I share this picture a lot. If you've seen it before in a presentation I've done, bear with me. But I took this picture on a trip. Isn't it beautiful? You guys love it? It's lovely, isn't it? I'll bet you wouldn't be able to tell what that is, but I actually took this picture at a really beautiful place. And on the day that we were at this place, there were a ton of tourists there, and a storm had come through. And we talked earlier about how trauma is a storm, and trauma really changes our view of things, right? It can alter the way that we see things, and it can alter our ability to see beauty. And so we know that this picture, I'm going to show you what it is in just a second in case you're dying to know, right? But this trauma lens sometimes is also how we see our clients. We see the storm and we don't always see the beauty underneath. Sometimes, if we're honest, our clients might get on our nerves, or they're really needy, or they're calling us a lot, or they're chaotic, or whatever might be happening. And that's what we're seeing. We're seeing them this way, right? But that picture I actually took standing on the rim of the Grand Canyon. Can't see it, can you? But I was right on the rim, looked right over the railing, and that's a picture of the Grand Canyon that I got on the day the storm came through. Unfortunately for our clients, our patients, people in their lives also see them this way, and they don't often see them this way, right? Sometimes that this pushes people away because it's too complicated and people don't want to know, and they don't bother to get to know that person underneath. And our job is to really understand how the storm might cloud our perspective, and how it might keep them from really being seen and valued. So when people tell their story of survival, it changes the perspective for them, for other people. Rather than telling the story about the wound, I encourage people to tell their story of their survival. right? Because then I can begin to uncover resilience and that really beautiful spirit that fought to survive, that fought to hold on. So even if it's tiny little bits that you're working to uncover, know that there's a beautiful person often that lies underneath all that storm cloud. And that's our job, is to understand that that person's there and to look for ways we can help them see that too. So I assess resilience in a couple of different ways. I assess resilience in terms of in spite of and because of, right? Two facets. So I might ask questions like, how did you survive, right? I want to know that. So in spite of your trauma, how did you get through that? How did you survive that? What did you tell yourself that allowed you to get up again and again and again? What was that thing? What did you do in the midst of your pain, and how did you do that, right? So if you took care of your kids, or you took care of your siblings, or you made it to school and you got to college and graduate school, how did you do that, right? That's a resilient person under there. I want to know. And then what kept them motivated to survive, right? And so those are questions that I might ask as I'm looking for resilience. And then again, because of the trauma and in spite of, so because of this, because of the trauma, what does survival mean to you, right? How are you stronger because of your experience? How are you more compassionate to other people, right? Often our trauma survivors are so compassionate toward other people. They're so sensitive. They're so tuned in. How did you learn to forgive if you're working on that? How did you break through pain? How are you wiser because of your experience? And maybe you can come up with other questions you want to explore. But in spite of, because of, and in spite of are two really important pieces to assess as you're talking to people about trauma. So fostering resilience, we talked about some of this already, is shining the light on hidden sources of resilience. So if somebody's, I mean, here's an example. If somebody's really codependent and they have trauma, I mean, definitely want to work on the codependence, but the fact that they still want to connect with people in spite of all their wounds, that's resilience to me, right? The fact that they're really tuned in, that maybe they're connecting so that they don't experience abandonment, that person still wants to be loved and accepted. And to me, that is a form of resilience. So I'm going to talk about that in that way, and then we're going to work on it, right? Because that's an escape behavior. Discussing resilience. I educate them a lot about resilience. I use that word. I talk to them about their strength. I talk to them about their potential in little bits. If we get too heavy, sometimes they shut it down, it's too much, or they may begin to doubt our authenticity. But find little ways to insert those concepts into your work with those patients. I talk a lot with people about this idea of integrity, since we addressed that early on in the presentation, right? Is that trauma was a threat to someone's integrity. So I want to talk to them about that, right? Because what we know is that when someone's integrity is impacted, is that often they have trouble understanding what their values are. They may behave in ways that are contrary to their internal values and morals. And that's often a result of trauma. So I want to know, what are their values? How is their integrity impacted? And I want to talk about spirituality. Now, sometimes, as we know, people get a little bit freaked out about that concept, and they feel like, well, spirituality is religion, and I don't go to church. So I have to educate them. So the way that I talk about spirituality with people that's helpful is I talk about spirituality as congruence, right? So that my insides match my outsides. So that my values, my morals, my sense of integrity, all are a match for how I'm behaving on the outside, how I treat other people, how I take care of myself. So I want to spend some time talking about spirituality as congruence, and people can usually get behind that idea. I don't have as much battle. If I start talking about religion or concepts around that, it's often very difficult for people. For people who do have some religious beliefs that are important to them, I want to know what those are, and I want to be able to talk those through with people as well. It's interesting to me that sometimes people who come from religious backgrounds feel guilty if they want to talk about their trauma. They feel like I should forgive and forget, or that I should be over this, or God healed everything and I don't need to talk about it, but clearly they're struggling. So giving them permission to really hold on to their values and do the work at the same time, and that both can actually happen at the same time, is an important concept for people to hear. I'm pretty firm when I'm working with people on trauma that I have a lot of boundaries around self-destructive behavior. So if somebody is actively self-harming, I will not do trauma work with them at that time, right? And often what I find is that people are motivated to work on their trauma. And so it's a nice motivator also to put a pause on self-harm and to begin to think about, okay, well, I want to do this work and I can't self-harm at the same time. And thankfully at Cottonwood, we have a low incidence of that, but occasionally people may scratch on their arm or they may do something like that. And then we're going to take a break because what they're telling me is they are too flooded and I'm not going to open that gate up more. Right? So what I found, and we talked about this earlier, is that often people are really activated by too many details. And so sometimes people need to talk about the details because shame is hiding in those details and we need to explore that. But sometimes being in the details for people is way too activating and they get stuck in all of that negative sort of spinning around and negative self-concept. So I made them lean more firmly into developing self-compassion, doing a lot of educating and teaching people to embrace sort of this new idea of themselves of being truly empowered in their recovery. But boundaries are really helpful in terms of what you're willing to tolerate as you're working with people, because they will get activated and those behaviors they'll want to move into things to take care of that pain or to manage that. So having those discussions openly, not in a punitive way, like, well, I'm not going to work with you then, but in a way that says, when that's happening, you're telling me that you're not managing that pain well. Let's work on developing some resources that help you cope. Let's get a container, right? We talk about a container, something to hold that pain, some way of being able to keep that pulled together so that we can do that work without you hurting yourself. And then I support small steps toward greater resilience a lot, even if it's itty bitty tiny ones, even if it's asking for help. One of the things I ask people to do when they have trauma is, number one, I have them begin to identify that they're angry. If they have trauma, they have anger, guarantee you, right? And often it's that powerless sort of anger that they've never been able to talk through. They've never had a voice. They had to be quiet. They had to keep it a secret. So being able to give them permission to say that they're angry is really important. Sometimes people are afraid, if I get angry, I'm going to explode everywhere. Chances are they don't, right? Often it's really hard for them to say, I feel angry, because they want to explain to people. So I say, try checking into your group or your meetings as being angry, and don't apologize to anyone. Don't say, oh, it's not about you, right? That crazy Kathleen told me to say that. No, it's not about you, right? To say instead, hey, I feel angry, and just sit with that and sit with people knowing that you're angry without taking care of them. It's a really good practice for people to be able to say the word anger and to know that they have a valid reason to be angry. And I'll say to them, if I were in your shoes, I'd feel really angry too, right? Giving them permission to talk about being angry is really important in healing. Teaching them how to identify what they need. Often our trauma survivors are really skilled at knowing what everyone else needs around them. They can walk into a room and assess how people are feeling, who's mad at who's tired, who had an argument with their spouse, right? Who needs extra support, but they don't have a clue what they need, right? That's an escape behavior. They learned that early on. I got to take care of everyone, and if I do a good job, I won't get abandoned or I won't get hurt. So teaching them how to tune into what they need and to say 3 things they need a day and get real clear and specific. Sometimes people aren't good at that, and they'll say, I need support, but what does that mean? Okay, if someone says to me, I need support, I don't know what that means. Teach them how to get specific and to take a risk in asking specifically for what they need from other people. And to know that other people might say no, and that's okay too. And to tolerate sort of the ebb and flow of relationships. Sometimes our trauma survivors don't know how to have safe and healthy relationships with other people. And so I tell them sometimes they might swing between not trusting anyone and no one gets into their world, and then trusting everyone and everyone gets in, right? And then going back and forth between the 2 ends of the spectrum. And the truth is that people should only be in our lives because they've earned the privilege to be there, because they're safe, because they're loyal, because they're honest, because we can trust them, they're kind, whatever the values are that we're seeking in relationships, and teaching them to identify how to know when someone's safe and not safe. It's a basic skill that many of our folks don't have. And as a result, they're either really lonely and shut down, or they continue to be in very abusive relationships. And they're often re-traumatized. So sort of teaching them to find those middle grounds. So we talked about finding meaning and also recognizing and honoring their own resilience. And as I said, teaching relentless self-compassion. Sometimes and we've heard this before, but I'll tell them to put their best friend filter on. If your best friend were struggling the way you're struggling now, what would you say to them? Would you get a razor and cut them if they were having a bad day? And they're often horrified. Oh no, I would never do that. Then it's not okay to do that to yourself. Okay? So if you wouldn't do it to someone you love and care about, you wouldn't say it to someone you love and care about, you're not allowed to say or do that to yourself. And so that's an important piece. And then we talked about finding a different narrative, beginning to tell a new story about how they survived what they survived. We talked about those. So as I said, I enjoy reading, and I don't know if anyone's read this book, Little Bee. It's a really powerful book, and I really appreciate this idea in this quote. But I tell you a little bit of a background on this story if you don't know it. Little Bee is the story of a Nigerian refugee who was put into, she escaped Nigeria after a really violent trauma. She's a young woman, and she's put into an internment camp in the UK where terrible things are happening to women there. They're being violated a lot. And so she learned, if she studied, if she became really smart, she learned to speak what she called the Queen's English, then often men would leave her alone. It was a protective piece for her. And on a mistake made by the camp, they're letting her free. It's a mistake, but they're going to let her out. So she's standing in line, and here's what she says. She's looking at the girl in front of her, and she says, "On the girl's brown legs, there were many small white scars. I was thinking, do those scars cover the whole of you like the stars and the moons on your dress? I thought that would be pretty too. And I ask you right here, please, to agree with me, that a scar is never ugly. That is what the scar makers want us to think. But you and I, we must make an agreement to defy them. We must see all scars as beauty, okay? This will be our secret." And I love this line because, take it from me, a scar does not form on the dying. A scar means I survived. In a few breaths' time, I will speak some sad words to you, but you must hear them as we have agreed to see scars now. Sad words are just another beauty. A sad story means this storyteller is alive. Do you hear the resilience in this? The next thing you know, something fine will happen to her, something marvelous, and then she will turn around and smile. So if you get a chance to read, it's a good book. It's a hard book to read, but it's a really powerful story of resilience and recovery. So with that, I want to say thank you very much.